Everyone, I hope you guys have been doing well. I know it's been a while since I've put out a video for you guys, but I wanted to try and get this out as soon as possible for you guys. That way, whenever it came to studying the vasculature of the abdomen, it'll come second nature to you guys whenever you start getting into the nitty-gritty details. So, first thing I want to do is kind of set the stage. How does the aorta get into the abdominal cavity? Well, the way I kind of remember all this is this little friendly mnemonic: I ate 10 eggs at 12. That stands for the IVC for the I, 8 meaning it's at T8's level. For the 10 eggs, it's T10 and it's esophagus. This is the spinal level where you see the esophagus enter into the abdomen. And then finally, the big one that we need to know is T12 or at 12. And that's when the aorta comes in. Here you can kind of see how they all come in, with the caval hiatus at T8, the esophagus coming in at T10, and finally the aorta at T12. I know that this can be significant whenever you're in regards to like OMM. What level or spinal level could you see like problems with each of these organs and how they would present? And you can kind of see how that would be significant. Say if somebody had somatic dysfunction at T8, somebody had somatic dysfunction at T10, or somatic dysfunction at T12. A kind of small thing to take note of is that the right cruise of the diaphragm will descend a little bit lower, all the way to L3, compared to the left cruise on L1, L2. Whenever it comes to the diaphragm with all these different attachment points, it's important to note that you have your median arcuate ligament, and that's where the aorta is going to be coming from. And as soon as the aorta comes out, and you'll notice this when in lab dissections, it'll give off an inferior phrenic artery. So that's kind of a quick way to kind of find that. In addition to, you'll have your medial arcuate ligament and your lateral arcuate ligament. And knowing that the psoas muscle will be coming through the medial arcuate ligament, and the lateral arcuate ligament gives off quadratus lumborum. These are really good landmarks. These muscles are really great landmarks to find the arcuate ligaments, and it'll kind of help you kind of discern like where you are in the abdomen in relation to finding everything. All right, so now that we've kind of set the stage of the diaphragm and entering how the aorta gets into the abdominal cavity, let's start getting into it. This lovely drawing, provided by one of my mentors whenever I did my master's program, Aly, she went ahead and made this design for all of the different branches coming off of the aorta into the abdominal trunk. It starts off, like I mentioned before, the eyeballs. You have a nose, you have a mouth, then you have the different arms. Then you will have essentially what are kind of the nipples, I don't know what else to say, for your different gonadal arteries. And then throughout it, as the aorta is descending down, it'll give off all of your lumbar branches, the IMA, and then you have your pelvis vasculature, where you have the bifurcation at L4, giving off your two different common iliacs, your right and your left. And then you'll have an internal and external iliac, which will eventually turn into femoral, and all of this hot mess that we'll get into later. But what I wanted to do is just kind of break it down slide by slide for each of the different branches. So we've already covered the eyeballs for Aorta Man, which is the inferior phrenic artery, right? So now we're going to go into the celiac trunk. This guy, he will be hanging out just above the stomach. You shouldn't have to flip the stomach or the greater omentum up in order to see it. And he will be just resting. Well, this picture does a great job over here to my right, showing exactly where it is in relation to the stomach. And then, of course, the liver will be somewhere kind of up here. Okay? So the celiac trunk has two great branches off of it, which will have, of course, smaller branches coming off of that. Towards the stomach, you will have the splenic artery. I love this artery because it's so cool. It's one of the few arteries that has kind of like a pigtail appearance, where it's very spirally, and its main job is to go straight towards the spleen, okay? hence the name splenic artery. You can't miss it. It will be behind the stomach, and like I said, it's coming at that L1 region where you can still see it, and it's just spiraling its way towards the spleen. As it's progressing to the spleen, it'll give off smaller, different pancreatic branches. As the name implies, it's going to be supplying the pancreas blood supply. Okay? And then once it gets to the spleen, it will come up and get the top part, or the fundus of the stomach. Okay? And that will give you your short gastric artery. And then also when it gets to the spleen, it will also give off your left gastro-omental artery. As you see here, it can also be called gastroepiploic, but I prefer gastro-omental because I just remembered greater omentum. So left gastro-omental artery. So you have a small branch going up to get the short gastric, and a large branch going down to do the greater curvature of the stomach, and that will be your left gastro-omental artery. Okay, and then for our next kind of smaller branch, we have our left gastric artery. Okay, now this one, it will be just coming up here to get this lesser curvature of the stomach. Over here we have the greater curvature, and here we have the lesser curvature of the stomach. This one will anastomose with this guy over here. So just like we have like a left gastro-omental artery here, that means you're going to have a right. So we have a left gastric artery coming up here, and this will also kind of supply the esophageal artery as well. So left gastric artery will come here, get the lesser curvature of the stomach, meeting up with the right gastric artery. So boom, we've got 2 of the 3 major branches coming off of the celiac trunk, which in of itself is like one of the big mama branches. So let's get into the third branch off of the celiac trunk, which is the common hepatic artery. Just like the name says, it's going towards the liver, or anything hepatic is usually associated with the liver, right? It is common because it's going to be splitting up. It will split up into a proper hepatic artery, and then you'll have this gastroduodenal artery. Okay? We'll start here before getting into this. The gastroduodenal artery, just as the name implies, will get the duodenum, and it will supply the right, what's the word I'm looking for? Right gastro-omental artery. And like I said before, it will anastomose with the left from the splenic artery at the greater curvature of the stomach. So as it's going down, and when you're in lab and you're kind of following this thing down inferiorly, just look for this big artery that's running into the greater omentum. I know the greater omentum can be kind of a mess, hence why we have this drawing here, but you'll just want to be looking for it, and it'll just follow along the bottom border of the stomach. Now, since we're at this Y junction, instead of following the greater curvature of the stomach, we will go into the pancreas and the duodenum, and this is called the supraduodenal artery, okay? And here you basically will have a bunch of smaller divisions based on where the pancreas is going. You have an anterior, posterior, and a superior and inferior pancreaticoduodenal. It's very hard to discern those just because the pancreas is such a fragile little organ whenever you're working on it. Just know that if it's coming from the top part of the pancreas and it's going in front of the pancreas, superior, anterior. If it's coming from the top part of the pancreas and it's going behind the pancreas, then it's going to be superior, posterior, right? So just kind of name it the way it's going. That's my best kind of advice there. And this is just kind of a word of warning. And this gets especially tricky when we get into the IMA. You and the pelvic vasculature, you will have quite a bit of variability where arteries are coming from. So when in doubt, just name it to where it's going, not necessarily where it's from. If it's coming from the source that you learned it, great. But the big thing is name it to where it's going, just like in OMM. Name it the way it likes to go. Okay, so we got through that big, ugly kind of like vasculature mess. And so now what we're going to do is we are going to go up from, instead of going inferiorly, we are going to work our way towards the liver. So we had our common hepatic artery branch, right? So we'll, just like whenever you have a left, you're going to have a right. Well, with a common, you're going to have a proper hepatic artery. One of my mentors had taught me that sometimes proper folk like to think that they're superior than the common folk. And so if you get the common and proper mixed up, think proper, think they're above or superior to the common hepatic artery, or the common folk, right? And so off of our proper hepatic artery, we will have our right gastric artery coming to meet with our left gastric artery from earlier to supply the lesser curvature of the stomach. You see that there? And then as it's going up, the proper hepatic artery will eventually be part of the portal triad, which I went ahead and listed over here. The portal triad is a good kind of division line going up to the liver right here. And that also helps us separate the lesser omentum, because I know lesser omentum can be kind of confusing, but behind this portal triad, or porta hepatis, is our lesser omentum. And the portal triad, which is a very high yield topic in my opinion, is the proper hepatic artery, your hepatic portal vein, and your common bile duct. Because remember that the cystic duct and the hepatic duct come together to form the common bile duct. And those guys are what makes up your portal triad. All right, so 1 down, 2 to go. Now that we've got through the celiac trunk, basically whenever you're in lab, you would essentially flip the greater omentum and flip the stomach superiorly, and just underneath it, not even that far apart, as you can see from our Aorta Man having the nose and then the mouth being so close, just like in a real person, the SMA is going to be extremely close to the celiac trunk, right? The best way to discern this, if you're in like a lab practical, is ask yourself, is the stomach flipped up or is it the stomach flipped down? That's a great quick way to kind of understand like where you are in a three-dimensional space whenever it comes to looking at these things from a lab perspective, since they are in such close proximity. Another big obvious reason is the SMA was now doing the midgut. All of this stuff was supplying the foregut, right? And now what we're going to be doing is the midgut organs. This is going to be including like your small intestines, the third and fourth part of your duodenum, your jejunum, your ileum, and your first 2/3 of your colon. Okay? So, for the SMA, or superior mesenteric artery, it will provide your jejunal and ileal arteries. And they can be the jejunal and ileal arteries can be extremely similar, but the way you discern them is that the jejunum will have long vasa rectae and few arcades. So let's kind of take a look at here. The jejunum is up here, obviously closest to the duodenum in the stomach, and it will have these super long, right here, vasa recta, right? But it will have very few arcades, which are these big kind of honeycomb areas, all right? Now, as you're getting close to the cecum in the large intestine / colon, you'll notice that you'll be having shorter vasa recta, okay? They'll be like essentially butting it right up against the small intestines, or the ileum, but you'll have very many arcades. I'm sorry, I forgot to change that up here, but you'll have a ton of arcades, these big honeycomb things just on top of the vasa recta. So short vasa recta for the ileum, but many honeycombed arcades. That's how you're able to discern it. I don't expect on the lab practical I think they'll make it abundantly obvious which one's which, whenever you're looking at it. Of course, obviously, besides the artery, you'll know that the ileum is right before you get to the cecum and the ascending colon, right? So the next big one is the ileocecal artery. This one will also have an appendigeal or appendix artery too that'll come in for obviously supply the artery for the appendix, which is this little dangly thing here on the cecum of the large intestines. So once again, this is the iliac artery, and this one's coming off of your SMA to do the cecum, which is the very beginning part of your ascending artery. And it's the area where the ileum meets with the large colon. Okay? And then this one will be the next big artery after your SMA is your right colic artery. This one, for obvious reasons, is going to your right colon or your ascending colon. This one could get confused with ileocolic. Just the best way to kind of discern the two is check to see, is it going at this kind of angle towards the cecum / appendix, or is it going straight to the right colon? So that's the best way to kind of discern those two when you're looking at the SMA. And then final artery of the SMA is the middle colic artery. This one is getting the transverse colon, right? And this one is important because it will anastomose with the left colon artery. And everyone knows anastomoses are extremely, extremely important because of the pathology that can be associated with them. The middle colic artery will anastomose with the left colic artery, and the left colic artery, which I'll get into later, is associated with the IMA versus this artery, which is the SMA. This point here, which is the marginal artery of Drummond, or located at the splenic flexure, because remember the spleen is located up here, is extremely important. Say if a patient crashed, hemorrhaged, or all of a sudden had a drastic drop in blood pressure, right? And so blood that's normally able to cross over here to the left colic artery, or vice versa from the left colic artery to middle colic artery, doesn't have the pressure required in order to supply this part of the large colon, right? Or large intestines. Well, now that we've had a decreased blood pressure, this part of the colon has an increased risk of becoming ischemic, or not getting enough blood supplied to it. So this part, because it's an anastomose between two separate artery branches, is exceptionally important to know about. So now we've gone through the phrenic arteries. We've gone through the celiac trunk. We just did the SMA, right? And now we have our left renal and right renal arteries. For renal, for obvious reasons, they are going straight to the kidney. Then we will have our gonadal arteries, which are going to be supplying the different gonad areas, such as, I believe, your testicular artery and your ovarian artery. I don't have that in front of me, but you'll have to double check on that. And then, of course, as it's going down, just like with the aorta and the thoracic cage, which is supplying all of the different posterior intercostal arteries, your aorta is supplying a ton of lumbar branches. Okay? So now we've gotten through that. So we know that the L1 area is going to be your celiac trunk and SMA. And now we're at the L3 vertebral level for the IMA, which is the inferior mesenteric artery. Okay? Cool. So I already went over here with our left colic flexure or splenic flexure, the marginal artery of Drummond, which is the anastomose from the SMA of the middle colic artery to the left colic artery. The left colic artery, once again, is getting the left colon, or the descending, because remember we're naming it in the way the food is traveling, the descending colon, right? And this one, we also have our sigmoid colon artery branches, or you could just say the sigmoid branches, going to the sigmoid colon, which is kind of like the very end part of the colon, right? It's also noted by having like an S for sigmoid. And then we have finally the rectum, where we have our superior rectal artery, right? This is also exceptionally important because just like with this one, how we had an anastomose up here, we have an anastomose here. The superior rectal, which is coming from the inferior mesenteric artery, will anastomose with the inferior rectal artery, which the inferior rectal artery is a branch of the internal pudendal, and the internal pudendal will come from the caval system. And I'll get into that later whenever I get into the pelvis, but it's an anastomose between like your caval blood, which is your non-GI related blood system, versus your portal blood system, or your GI related blood system, right? So once again, that's just something that we'll get into later, but the big 3 branches you need to get out for the IMA is your left colic, your sigmoid artery, and your superior rectal artery. All right, and before I wrap up and start getting into pelvis stuff, I really wanted to try and get into the venous system. The venous system can be a little confusing, but I wanted to hit some high notes for you. The big thing is that everything's, you remember that portal triad we talked about at the beginning of this video? Well, here's the portal vein, right? That's going to be going back up there with the proper hepatic artery and the common bile duct, right? This thing is bringing all of the blood from your GI system, so all that potential drinks, sodas, cheeseburgers, whatever you had consumed, now needs to get filtered in the liver to get rid of any of the toxic stuff before making its way back up to the heart to go back into general circulation. So this is the main blood supply going back to the liver for it to be filtered out, essentially, or kind of like a Brita filter. Okay? The big thing to know is that the splenic vein is coming all the way across. And I know vasculature can be variable, but for the most part, your inferior mesenteric vein, which is basically draining everything that the inferior mesenteric artery supplies, your left colon, your sigmoid colon, and your superior rectum, is going to go directly into your splenic vein. So your inferior mesenteric vein is going straight up to the splenic vein. Okay? And your superior mesenteric vein is going straight up here. So they almost kind of come together. So the splenic vein and the superior mesenteric vein come together to form the portal vein. Okay? So those are your 2 main branches. So the big thing to know is that the inferior mesenteric vein comes up to the splenic, and then they will come and converge here at the portal vein. The other big thing to kind of know is that, you know how I was talking about you had your different anastomoses with your superior and inferior rectal vein? Well, there's 2 other anastomoses which I failed to mention. It is your gastric vein and your esophageal vein. Your esophageal vein will be coming off of your azygous vein that we studied in thoracic, right? And your gastric vein, which is the one we had already talked about from the left gastric artery on the lesser curvature of the stomach. These 2 will meet, and it's important because the gastric vein coming from your digestive blood supply, or your portal blood supply, will converge with your caval blood supply, or your esophageal vein. They meet at the Z line. Inferior to the Z line of the esophagus is going to be your caval system, or your esophageal, or is going to be your gastric vein, your portal system. And above or superior to the Z line is going to be your caval system, your esophageal vein coming from your azygous vein, right? Well, let's say like the liver got backed up, whether the patient's having liver failure or some sort of blockage is preventing the blood supply to go through the liver before going back to the heart. Well, the blood's just not going to sit there. It's got to go somewhere else. And so instead of it just getting blocked up, just like if traffic was blocked up on Rogers Avenue, you would sit there and take like a side road like Phoenix or Free Ferry, right? Well, these are basically the Free Ferry and Phoenix of the blood supply. So instead of it waiting its turn to go to the liver, it will instead back up and go through the caval system. This backup can cause what's called esophageal varices, right? Esophageal varices is whenever you will have, it can often present as kind of like an upper GI bleed, where it will an aneurysm and it will proceed to bleed inside the stomach because of all these like large blebbing inside the esophagus. I know that this can be a big thing because it can be silent until a patient actually notices. Esophageal varices can also be associated with GERD. You might notice that for like any sort of superior movement of the Z line, right? And GERD is a gastroesophageal reflux disease or acid reflux disease, right? The other kind of important anastomosis is your superior rectal and inferior rectal. Superior rectal, as I mentioned, is coming from the IMA or your portal system, and your inferior rectal, which is coming from your internal pudendal artery or your caval system, standing for inferior vena cava, right? Whenever these get backed up, you can have what's called hemorrhoids. These can be exceptionally painful, especially if they are below the pectinate line. There you have somatic innervation, which is extremely, extremely painful or sensitive, kind of like whenever you have somatic sensation in your fingers or any of your legs. However, if you have hemorrhoids, internal hemorrhoids above the pectinate line, where you are, what's the word I'm looking for? It's not somatic, maybe enteric. But if it's above the pectinate line and you have hemorrhoids, the patient, with the exception of noticing blood in their bright red blood in their stool, would have no clue that they had hemorrhoids going on. So that's something to kind of note. So if they have, and this is once again caused from a backup in the liver, and so these kind of blood vessels or veins will tend to become extremely enlarged or engorged and have a good chance of tearing. Okay? And then finally, we have our anastomosis between your para-umbilical, which is part of your portal venous blood supply, and your superficial epigastric veins. The important thing to note is this extremely outstanding photo that is impossible to forget is called caput medusa. Medusa, kind of like with Medusa's snake hair. And this, once again, is caused by a backup due to liver failure or some sort of obstruction in the venous system going into the liver. And so, like I said, it just looks like a bag of worms or something coming through there. So instead, the veins going to that normally you wouldn't even notice or didn't even know existed unless if you knew what to look for, have become engorged and just extremely, extremely noticeable because the normal way of blood going back through the liver has now been obstructed and it has to get back to the heart some way. And so instead, it uses the superficial epigastric vein to get there. The kind of mnemonic is your gut, your butt, and caput is kind of the way to remember these different anastomoses. I know one thing I did not note here, but you for sure should know about, is called Nutcracker Syndrome. Here I have this kind of little rough black and white drawing, but you have the SMA goes directly over your left renal vein. Now, your kidneys are kind of hard to visualize unless if you have some sort of CT or ultrasound. But the significant thing to note for your left renal vein is that you have your left testicular vein coming in here. So if you're a male, you may not notice like possible kidney atrophy or some sort or inability to drain the kidney in your adrenal gland. But you will for sure notice if your left testicle is becoming extremely swollen because now your left testicle has no way of properly draining its blood contents. And so the patient will present with extremely painful, and they'll specify left testicle, not just testicle in general. And you will note it, and you could probably order an image showing that the SMA is extremely swollen, possibly aneurysm, and it's called Nutcracker Syndrome. And that is coming over here, as opposed to the right testicular vein, which is draining directly into the inferior vena cava right here. So the left testicular vein can be blocked from having a swollen SMA coming over the top of your left renal vein. And for that, before I get into, before I get into pelvic vasculature, I think I'm going to break this up into 2 separate videos so that way you guys aren't completely overwhelmed. I look forward to talking to you guys over pelvic vasculature next.